Hi everyone. So today we are going to discuss about traumatic injuries to the permanent dentition. So I will be covering the topics that are most important for the ADC exam point of view. So one of the questions that they do ask in the exam is the type of injury that is seen with the permanent dentition, or it's the type of injuries that you see more with the primary dentition. So in the primary dentition, you usually see more of luxation injuries, whereas in the permanent dentition you see more of crown fracture. So that is one of the MCQs that is asked in the exam. Now whenever you have a patient who comes with a history of trauma, there are certain things that you need to check before you proceed with the dental examination. So you need to ask the patient if he had any episode of headache, nausea or vomiting, because any episode of headache, nausea or vomiting may indicate that there is some amount of head injury, and that is something that has to be on the priority list and has to be ruled out before we proceed with the dental examination. Also, if the tooth was injured and has been broken down and a part of the tooth is missing, and if the patient or the parents could not find the part of the missing tooth and there was an episode of breathlessness, it is always good to have a chest x-ray done to rule out if the part of the missing tooth was ingested by the kid. So that is one of the things that you will keep in your mind before you proceed with the dental examination. Now, most of the cases of trauma or accidents, they usually come in as an emergency situation, leaving very less time for an elaborate dental history or examination. But there are certain things that you need to ask and have and note down in your dental notes before you proceed with examination. They are not only important for the treatment point of view, but they are also important for medical legal purposes, and they have to be maintained in the record. First of them is the time. Not only the day, but the exact timing of the incident is very important. The reason for this is because prognosis of many of the treatments that you will provide for dental treatment, like the prognosis will depend upon the time that has elapsed since the injury occurred. For example, in cases like avulsions, the prognosis is very good if the patient comes to you within some minutes since the incident occurred, and the prognosis would go way down after 30 minutes, like especially like when the time elapsed is more. So even in complicated fractures, the prognosis would highly depend upon the timing. So the exact timing has to be noted down. The second reason why we note down time is because delayed treatment timings have been associated with child abuse and neglect. So if you find a patient who has been having a history of trauma and the patient comes in with delayed treatment timings, it has to be maintained in your records for medical legal purposes. The second important aspect is where the trauma occurred, whether it was indoors or outdoors. Again, it's going to give you an idea of the degree of contamination of the wound. So something that occurs in a playground or outdoors is obviously going to be more contaminated, because in a situation like, suppose if tooth is avulsed, it is completely knocked out of the socket, and that happens in a playground. So the tooth is going to be more infected than if it happens in the room or it happens in the house. So these things are supposed to be kept in mind, because they might change your treatment plan. Like in a case of avulsion, you might give antibiotics to prevent the infection from happening. So these things are to be known. And the third thing is, how did the trauma occur? That is the mechanism of injury. This has to be known because if it is a roadside accident, so you know the impact of the wound. If it was a fight, you have to know if anybody else was injured, if there was any other injury that occurred. And also for medical legal purposes, you have to have a record of the same. The other thing is that we could implement a preventive protocol in future. By that I mean, if the injury occurred during a sports activity and the child was not wearing a mouth guard, it could be implemented in future so that such incidences do not happen again. next time. So that is the reason why these things are very important. Apart from this, the medical history is very important, especially any bleeding disorders or any medical problems. They should be taken in account because they are going to change your treatment plan. And the past dental history, if these things have been happening over and over again, you have to have it in your records to know if it is a child abuse case or what can be done to prevent these things from happening in future. Now coming to our trauma protocol, we can remember it with an acronym, and the acronym is trauma, and it's spelled a bit differently. We use a V instead of a U here. So our T stands for tetanus booster, and it's true only in cases of avulsions where the tooth has been knocked out and the plan is to reimplant it. So we need to prevent infection from happening. So you need a tetanus booster in the first 48 hours within the injury timing. Our R stands for radiograph, that is, at least you would need one PA in most of the cases, and in some cases like jaw trauma or suspected jaw fractures, you may need a panoramic X-ray. In some situations, you may require more than one PA, and we will be talking about it in the coming slides. Our A stands for antibiotics, which is again true only in cases of avulsions. Like I said to you before, the tooth has been knocked out, and to prevent the infection from happening, we need to give antibiotics. So yeah, it's true only for avulsions. Our U, that is our V, stands for vitality test, which is the EPT and the cold test. Now keep in mind that these tests do not test for the true vitality of the teeth. The true vitality of the teeth is the vascular supply of the tooth. But these tests actually check for the sensory supply of the tooth, which may be disrupted from 2 to 8 weeks after an incident of trauma. But you usually take it for a baseline record. This is again one of the most important MCQ asked in the ADC exam. So what do? We monitor with more appointments. So our M and our A is more appointments, and the more appointments would be at 3 weeks, 3 months, 6 months and 1 year. So this is our trauma protocol, and it has to be applied in most of the trauma cases. Now Ellis classification is very important, and I have put up a table here so that you can remember it. Some of the classification numbers are easy, and I will give you a way to remember it, and the rest of them you can just keep it in your memory banks. So Ellis class 1 involves one layer of the tooth, so that is the enamel. Ellis class 2 has 2 layers of the tooth, the enamel and the dentine, whereas Ellis class 3 has 3 layers of the tooth, enamel, dentine and the pulp. Ellis class 4 kills the tooth. Ellis class 5 kicks the tooth. So you could also remember avulsions, as avulsions has V in it, and it stands for a Roman 5. So Ellis class 5 is an avulsion, and the rest of them you can just see the table and remember it. But the first 5 ones are very easy to remember, and they are usually tested on the board exam. So you have to keep them in your mind to answer any question. Now coming to the treatment part, so if you have an Ellis class 1, you would actually, for the treatment, you would just round out the sharp edges if there are any, so that it does not lacerate the soft tissue any further. And also you would advise a soft diet, and you would recall the patient with more appointments. If the enamel and the dentine is broken, you would elect to restore the tooth with something like a composite resin or something, so that you even restore the function and aesthetics. And also when you restore the tooth, you occlude the dentinal tubules that have been exposed, so you reduce the sensitivity that's present after the fracture. Treatment of choice would also be that if you have the part of the missing tooth available, it could be bonded back to the tooth. In both of the cases, you would advise a soft diet for the patient, because if the patient bites on anything hard, it's going to be more sensitive since there has been an impact of trauma. Before we go to class 3, Ellis class 3, I would like to discuss about complicated and uncomplicated fracture. An uncomplicated fracture does not involve the pulp, so there is no pulp treatment that you would give in those cases. But the fractures that involve the pulp are considered as complicated fractures, and you need to give some amount of treatment to the pulp. So in Ellis class 3, you have the pulp that is involved, and the treatment would actually depend if the tooth has open apex or closed apex. Now what do I mean by open apex and closed apex is open apex that the root is not mature and it's still forming, and closed apex is that the root is mature and has been formed completely. Now keep in mind that open apex has better prognosis than closed apex. So you can just have a look at this table over here which I have put up, but also for test purposes, like you could remember that if the trauma occurred before like less than 24 hours, you could get away by doing a pulp cap. Okay, if the trauma has occurred like more than or equal to 24 hours, then you may do a CBEC pulpotomy where you remove the part of the coronal infected pulp. Okay, and if the trauma occurred like more than 72 hours or equal to 72 hours before, then you may need to do a pulpotomy where you remove the entire part of the infected pulp. So this is something that you can just keep in your mind for the test purposes. Again, if it is necrotic, then you may need to do a root canal treatment. There are some clinical pictures that I have put up. You can just pause the video and have a look at it. Now coming to root fractures, we will be talking about horizontal root fracture. Now this is one of the situations where we may actually need more than one PA. The reason why we need more than one PA is because a fracture like this suppose happens, and if you take an X-ray is a 2D image of a 3D objects. So if the beam of X-ray beam is in alignment with the fracture line, you might not actually see the fracture line on the X-ray. That is the reason why you may need PA at different vertical angulations. Maybe you may need 3 PA and 1 occlusal. The occlusal will be at 90 degrees to the long axis on the tooth. So hopefully with all these 3 PAs and occlusal, you will be able to see the fracture line. Now what happens in a horizontal fracture is, let's go back to the slide, is that the coronal segment may be mobile and the apical segment is not mobile. Now, one of the short forms to remember in root fracture, for horizontal root fracture, is ABC. So it means that apical is better than coronal. What I mean to say is that if a fracture occurs in the apical segment, it's better and is going to have a better prognosis than if it occurs in the coronal segment. So if the fracture occurs in a coronal segment, it will require splinting for a longer period of time, and the prognosis is not as good as it would be for an apical segment. So there are chances of the side effects like ankylosis would come into picture in these in the coronal fractures when you splint it for a longer period of time. Now coming to the treatment of the horizontal root fracture, now there can be two scenarios. Like now the coronal segment is mobile and is vital. So if the tooth is vital, we will reposition and splint it. Okay, and if it's not vital, you will need to do a root canal treatment. So it makes sense. If it's vital, we reposition it for healing and to reduce the discomfort and splint it. Now the splinting, if apical, it will be for a less amount of time. If coronal, greater amount of time, right? Now if it's non-vital, now we consider the apical segment and the coronal segment. So if the coronal segment is non-vital, we would do a root canal treatment and we would seal off the wide lumen. But the necrosis of the apical segment is very, very rare, and if that happens, we can surgically treat it or extract it. Yeah, so that is the treatment for the root fracture. Now if the tooth is vital and we splint it, the healing will take place by a callus formation. So a callus will form between the two fractured segment and the healing will take place, and this is called as calcific metamorphosis. Again, a very important topic for the MCQs for the exam. So you have to remember that the healing takes place by calcific metamorphosis. Another important thing that I would like to tell you, just for the MCQ point of view, that oblique fractures are better than transverse fractures. So apical better than coronal, ABC, and oblique better than transverse. So for root fractures, you could just remember this. Now let's come to concussion. Now to remember concussion, you could remember that something like you're going and you just bumped your head on the wall. I think everybody has bumped their head once in a while. So that is something that is similar to concussion. Now your head is going to be sore and you're going to rest for some time. So in the figure you see concussion. Suppose you bumped your tooth and now the tooth is a bit sore. So the only thing that you're going to do is going to have a soft diet and give the teeth some rest. And you're not going to bite on anything that's hard. But in a scenario where you bumped your tooth, now you have bleeding, there is a bit of mobility, but the tooth has not been displaced. So the patient comes to you with some amount of bleeding around the gingival sulcus, and the tooth is a bit mobile, but the tooth has not been displaced. So be sure that there is some amount of subluxation. It's not just concussion. So the treatment here would be splinting for a short period of time, around 2 weeks, a soft diet, and monitor the tooth with more appointments. Here are some clinical pictures which I am putting it up, and you can have a look at it by just pausing the video. Coming to the topic of extrusion. Extrusion is the tooth has been partially extruded out of the socket. Okay. Now again, open apices, better prognosis than closed apices. So what you would ideally do is reposition the tooth, flexible splint, and monitor. Now chances of necrosis are around 65%, and if that happens, 65% with closed apices. So if that happens, you would commence with an RCT. But the first thing is that you would reposition flexible splint and wait and observe for extrusion. Now, lateral luxation is a scenario where the tooth moves in one direction and the root moves in another. So mostly the tooth moves palatally and the root moves in the other direction. So sometimes you may have the fracture of the alveolar bone. So this is something that is more sinister compared to extrusion. So it requires splinting for a longer period of time. The treatment is same like extrusion, but the amount of splinting will be the time period for splinting would be greater than extrusion, and there is around 80% chances of necrosis with closed apices. Now keep in mind, with all our injuries, open apices have better prognosis than closed apices. So this is something that you should keep in your memory banks. Now intrusion is very traumatic and is very important topic for exam point of view. You would definitely have one question on intrusion. Now the treatment for this is different than compared to others, so you have to just remember it that if it's a closed apices, okay, the chances of necrosis are 96%, and the reason for that is when the tooth is intruded in the socket, it literally would sever the blood supply of the tooth. So the chances of survival for a permanent, like a mature root, is very less. So the treatment here for a mature root would be reposition, flexible splint, and commence with a root canal treatment. For an open apex, you would actually do nothing. You would let it erupt on its own. It might take a few hiccups, but it will come back and erupt on its own. So intrusion is different than all other treatment modalities. For open apices, do nothing. Like you have to wait and give the teeth time to erupt before you go with ortho or think of going for surgical or ortho. These are the options which you would consider later on. And with closed apices, reposition, flexible splint, and root canal. And the reason is because the chances of necrosis are 96% with closed apices. Now coming to the topic of avulsion, it's very traumatic. Suppose Jack is playing in a playground and he got hit by a golf ball or by some ball or something, and he knocked off his couple of teeth. So this is a classic case of avulsion. Now the most important factor to be remembered here is EADT, that is the extra alveolus dry time, the amount of time the tooth is out of the socket and is dry. So that is anything in couple of minutes is well and good and has a better prognosis, and the prognosis would go way down when the timing goes more than 30 minutes. So when the patient calls you and says that he has knocked out his tooth, there are some information that you can give him which is in the table and you can just read it. But there are some transport medias which are very important and they are asked in the ADC exam. These are the ones in which the tooth can be kept when he is driving to the patient to the clinic. So the first of them is HBSS, that is the Hank's Balance Salt Solution, which is also called as Save a Tooth. But suppose if that's not available, the tooth can be kept in milk, saline, or even the patient's own saliva if he is mature enough to hold the teeth in the mouth without swallowing it. And yeah, water is least desirable out of all of this. So it's not something that you are going to advise a patient to keep the tooth in water, because it's not desirable that you do it. So this is one of the questions that they ask in exam. Now also another thing is that I would like to mention is that this is one scenario where closed apices have better prognosis than open apices. So this is the reverse. All the situations we had that open apices always had better prognosis, but in this situation it would be closed apices, and anything less than 60 minutes would have a better prognosis, and not all the teeth can be reimplanted. There are certain exceptions depending upon the timing, depending upon the apices. You might elect to not reimplant the tooth. Yeah. So for test purposes, if you have to remember, if the tooth has to be reimplanted, that is a permanent tooth, primary teeth are not reimplanted. So if the tooth has to be reimplanted, it would be reposition, flexible splint, and monitor. This is just generalization, and it will help you to solve some of the scenario based questions that are asked in exam. But again, open apices more than 60 minutes, you may decide not to reimplant, and doesn't have that better prognosis when compared to closed apices. So yeah, these are some clinical pictures and you can have a look, and in the part 2 I will be discussing about the side effects and some of the scenarios and how to answer these questions.